What if I told you that the position you're lying in right now could be forcing stomach acid directly into your esophagus for the next 8 hours, and that 6 bedtime habits millions of older adults follow every single night are silently creating damage that takes decades to develop but only moments to prevent? I'm Dr. Michael Hayes, board-certified gastroenterologist, and in 18 years of treating digestive disorders, I've performed over 3,000 endoscopies, and I can tell you with absolute certainty that what you do in the 3 hours before sleep will determine whether your stomach spends the night healing or bathing in acid that shouldn't be there. If you're over 60, if someone you love is over 60, if you're dealing with heartburn or unexplained throat problems or chronic cough, please stay with me because what I'm about to explain could save you from years of suffering and conditions that are completely preventable. Here's what most people fundamentally misunderstand about nighttime digestion. Your body uses those sleeping hours to repair damage, to calm inflammation, to let your esophagus and stomach recover from everything you expose them to during the day. But when you make even one of these 6 mistakes, you transform healing hours into hours of assault, and your body over 60 doesn't have the resilience it had at 30 to compensate. The lower esophageal sphincter, that valve between your esophagus and stomach, naturally weakens with age. Acid production changes, gastric emptying slows, tissue repair becomes less efficient. Habits that caused minor discomfort when you were younger now cause serious progressive damage, and I see this pattern constantly. People who ignored mild symptoms for years suddenly facing Barrett's esophagus, severe inflammation, strictures that make swallowing difficult, changes in tissue requiring intervention that could have been completely avoided. Let me start with the habit that shocks almost every patient: sleeping on your right side. This sounds too simple to matter, but the anatomy is fascinating, and once you understand it, you'll never think about sleep position the same way. Your stomach sits predominantly on the left side of your body, and the point where your esophagus connects, the gastroesophageal junction, is at the upper left portion of your stomach. When you lie on your right side, gravity pulls all stomach contents, the food, liquid, acid, directly toward that junction. The lower esophageal sphincter, already weaker in most people over 60, is under constant pressure from pooled stomach contents. And because you're lying down, there's no gravitational help keeping things where they belong. Acid flows up, sits in your esophagus, refluxes into your throat, can reach your larynx and lungs. Contrast that with sleeping on your left side. When you're on your left, the anatomy works in your favor. The esophagus enters from the right side of your body, so lying left means the junction is elevated above pooled stomach contents. Gravity helps that valve instead of fighting it. Acid stays in your stomach where the lining can handle it, and your esophagus gets relief. Multiple studies show left-side sleeping reduces reflux episodes, reduces esophageal acid exposure, improves symptoms dramatically, yet almost nobody knows this. If this is making sense, subscribe right now so you don't miss next week's video where I'm covering foods secretly causing inflammation even though they're supposed to be healthy. I remember Linda, 67, accountant from Michigan, who came in exhausted because she hadn't slept through a full night in over a year, waking up choking, coughing, unable to breathe, horrible burning in her throat. She'd tried 3 different medications, eliminated trigger foods, elevated her bed, nothing worked. I asked which side she slept on. Right side, always had, felt natural. I explained the anatomy, drew a picture of where her stomach sits and how gravity works differently by position, asked her to try left side sleeping for 2 weeks. She called 12 days later with emotion in her voice. "Dr. Hayes, I haven't woken up choking once. My throat doesn't hurt. I'm sleeping through the night." That's how dramatic this change can be, and it costs nothing. The second habit is eating within 3 hours of lying down, and modern life makes this difficult, but the science is clear. This sets you up for reflux, and age makes it worse. As we age, gastric emptying, the process where your stomach breaks down food and moves it to your small intestine, takes significantly longer in people over 60. Acid production changes, protective mucus thins, muscular contractions propelling food become less vigorous. When you eat dinner at 7 and go to bed at 9:30, your stomach is still working on that meal, full, churning, producing acid, and lying flat removes your one advantage, gravity. Upright, even with a weak sphincter, gravity helps keep contents down. Recline, and you've eliminated that assistance. The valve works alone against a full stomach's pressure. For someone over 60 with sphincter weakness, likely with a hiatal hernia, which is incredibly common, possibly taking medications that relax that valve further, this guarantees problems. Acid doesn't occasionally splash up. It pools in your esophagus, sits there, causes inflammation, and night after night, this repeated exposure changes tissue. Many older adults don't feel classic heartburn. They have silent reflux where acid reaches the throat and voice box without chest burning, so they don't know it's happening. They're just hoarse every morning, have chronic cough, feel something stuck in their throat, never connecting it to dinner timing. Richard, 71, retired postal worker from Florida, came to me because he'd lost his voice, hoarse for 6 months. ENT found vocal cord inflammation, but couldn't determine why. I asked about eating schedules. Dinner at 8 or 8:30, bed around 10 to watch news. I explained he needed 3 to 4 hours between last meal and lying down. Skeptical but willing, he moved dinner to 6, stayed upright until 10. 3 weeks later, his voice started returning. 6 weeks. Hoarseness completely gone. Drop a comment and tell me what time you usually eat dinner. I'm curious how many people face this timing issue without realizing it affects their symptoms. The solution seems obvious once you know, but consequences of not knowing are severe. Chronic acid exposure causes esophagitis, inflammation of esophageal lining. Untreated esophagitis leads to erosions, then ulcers, then strictures where scar tissue narrows your esophagus, making swallowing difficult. Chronic inflammation over years can lead to Barrett's esophagus, where normal squamous cells are replaced by columnar cells resembling intestinal lining, and Barrett's carries increased risk of esophageal adenocarcinoma. This takes years, usually decades, happening silently while you sleep, triggered by something as simple as eating too close to bedtime. If your schedule makes early eating difficult, you have options. Eat smaller dinner portions so your stomach empties faster. Make evening meals lighter, lean protein, non-acidic vegetables, easily digestible foods. Stay upright as long as possible after eating. Every additional 30 minutes helps. If you must eat late, choose something minimal like almonds or a banana, not a full meal. Talk to your doctor about whether medication schedules contribute to delayed gastric emptying. Some medications slow digestion and timing can be adjusted. The third habit is taking medications incorrectly at night. Critical because the average person over 65 takes 4 to 6 prescriptions, many either directly irritating the stomach or affecting digestive function. Non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, naproxen, aspirin, work by inhibiting cyclooxygenase, and blocking that enzyme reduces protective stomach mucus. Taking NSAIDs at night, especially on empty stomach or before bed, creates vulnerability where your lining is less protected. Then lying down means any reflux hits less protected tissue. Over time, this causes gastritis, ulcers, bleeding. Many older adults take low-dose aspirin for cardiovascular protection at night, unaware it's contributing to stomach problems. Bisphosphonates for osteoporosis, commonly prescribed to women over 60, have specific administration rules. Take first thing morning with full water glass, remain upright 30 minutes minimum, because taking them and lying down causes severe esophageal irritation, ulcers, sometimes strictures. I've seen patients take bisphosphonates at night because they forgot morning dosing, ending with horrific esophageal damage requiring months to heal. The medication doesn't absorb properly lying down either, so harm without benefit. Medications that relax the lower esophageal sphincter include certain blood pressure drugs, particularly calcium channel blockers, some antidepressants, especially tricyclics, benzodiazepines and sedatives, anticholinergics, nitrates for heart conditions. All chemically weaken the valve, keeping acid in your stomach. Taking them at night, then lying down pharmacologically makes reflux more likely. I'm not saying stop these medications, many are life-saving, but have informed conversation with your doctor about timing, dose adjustment, alternatives without same digestive effects. If you found this helpful, hit the like button now. It helps this reach more people who need it, and subscribe because I post new gastroenterology content weekly you won't want to miss. What I do with patients is ask them to bring every medication, prescription, and over-the-counter we review together. What time they take each, with food or without, potential interactions, side effects they might not have connected. Very often we find opportunities adjusting timing or sequencing that significantly reduces digestive symptoms without stopping anything. Someone taking calcium channel blocker at night with reflux might switch to morning dosing after consulting their cardiologist. Someone taking NSAID at bedtime might switch to breakfast and use different pain management at night. These require medical supervision. You cannot change medication schedules alone, but they make enormous difference. The fourth habit is ignoring mild symptoms, perhaps most dangerous because it allows small problems becoming big over years without realization. You have heartburn once or twice weekly, not severe, just uncomfortable. Take antacid, it goes away, you forget. Wake with sour taste some mornings, brush teeth, it's gone, don't think again. Voice slightly hoarse, clear throat frequently, figure it's allergies. Vague upper abdomen discomfort after meals, not pain exactly, just fullness or pressure eventually fading. These seem minor, non-debilitating, so you don't mention them to your doctor, or minimize them saying, oh, it's nothing really, just a little heartburn. But reality, those minor symptoms are evidence acid repeatedly touching tissue not designed for acid. Your esophagus lacks protective stomach lining. Esophageal cells are squamous epithelium, delicate, meant for food passing through, not acid sitting on them. Every reflux episode, even brief, even painless, causes cellular damage. Your body tries repairing, but frequent insult means repair can't keep pace. You develop chronic inflammation causing cellular level changes. This brings Barrett's esophagus, one of most preventable conditions I deal with, yet I see new cases weekly. Barrett's is where normal squamous cells lining lower esophagus are replaced by columnar cells normally in intestines. This happens as adaptive response to chronic acid exposure. The body says, okay, these squamous cells keep getting damaged. Let me replace with cells handling acid better. Problem is, these new columnar cells, while more acid resistant, have small but real dysplasia risk, abnormal changes, and dysplasia can progress to adenocarcinoma, esophageal cancer. Let me clarify numbers because I don't want panic. Not everyone with Barrett's develops cancer, vast majority do not. Annual progression risk from Barrett's to cancer is less than 1%. But that risk is still significantly higher than without Barrett's, and once you have it, you need regular surveillance endoscopy every few years monitoring changes. That's burden, expensive, uncomfortable, completely avoidable addressing reflux early. Dorothy, 74, retired nurse from Pennsylvania, came not for reflux but trouble swallowing. Food felt stuck in chest, constant water drinking to wash things down, 12 pounds lost over 6 months without trying. Endoscopy found Barrett's with high-grade dysplasia, cells showing significant abnormal changes, and early cancer. We treated endoscopically, didn't need surgery, but required multiple procedures and months follow-up. When I asked reflux history, she said, oh yes, heartburn probably 20 years, just took Tums, didn't worry. 20 years, 2 decades, chronic acid exposure never mentioned to doctor because it seemed minor. That's the danger, ignoring mild symptoms. Comment below how long you've been dealing with reflux symptoms and whether you've had endoscopy. I'm curious how many walk around with undiagnosed conditions. If you're having heartburn more than twice weekly, see a doctor. Using over-the-counter antacids more than twice weekly for over 2 weeks, need evaluation. Difficulty swallowing, even occasional, need endoscopy. Chronic hoarseness, chronic cough, chronic throat clearing, asthma worse at night. Any can signal reflux reaching throat requiring evaluation. Chest pain, even if you're sure it's reflux not heart, get checked because you can't assume. Nausea without obvious cause, unexplained weight loss, any blood and vomit or stool, these are red flags requiring immediate attention. Upper endoscopy allows direct esophageal and stomach lining visualization, seeing inflammation, Barrett's if present, taking biopsies. Procedure done with sedation, you feel nothing, takes 10 to 15 minutes. If we find Barrett's without dysplasia, we monitor with surveillance endoscopies every 3 to 5 years. Low-grade dysplasia, more frequent monitoring or endoscopic treatment with radiofrequency ablation destroying abnormal cells. High-grade dysplasia or early cancer, often endoscopic treatment without surgery, excellent cure rates if caught early. Wait until severe symptoms, advanced cancer, treatment is aggressive and outcomes less certain. That's why I'm passionate about early evaluation, not ignoring symptoms, understanding mild symptoms today warn of serious problems tomorrow. The fifth habit is consuming specific evening foods and beverages known triggering reflux. And though most heard general advice about triggers, few understand mechanisms why these are problematic or how to time strategically. Alcohol is worst for multiple reasons. Directly relaxes lower esophageal sphincter, valve opens easier and stays open longer. Stimulates stomach acid production, creating more acid while weakening barrier containing it. Delays gastric emptying, food and liquids sit longer, increasing pressure and reflux likelihood. Can directly damage esophageal mucosa, making it more vulnerable. Glass of wine or cocktail with dinner then bed 2 hours later essentially guarantees reflux. For people over 60 whose sphincter tone is already compromised, this magnifies. Caffeine from coffee, tea, chocolate, some sodas, energy drinks also relaxes sphincter and stimulates acid secretion. Chocolate particularly problematic, containing both caffeine and theobromine, relaxing smooth muscle plus high fat. High-fat foods, fatty meat cuts, fried foods, heavy cream sauces, full-fat dairy, take significantly longer digesting than lean proteins or carbohydrates. Fat delays gastric emptying, stomach stays full longer, increases sphincter pressure, increases reflux risk. Additionally, fat stimulates cholecystokinin release, hormone relaxing lower esophageal sphincter. Fatty foods hit multiple angles. Spicy foods, hot peppers, cayenne, chili powder, directly irritate already inflamed esophageal lining. While not necessarily causing reflux in everyone, if you have esophagitis, spicy food worsens it. Acidic foods like tomatoes, citrus, vinegar add more acid to already acidic environment. If esophageal lining is compromised, you're intensifying damage. Mint, often consumed as tea thinking it's soothing, actually relaxes lower esophageal sphincter. Peppermint tea before bed can worsen reflux. Carbonated beverages introduce stomach gas, increasing pressure, causing belching. Every belch is acid opportunity coming up with gas. I'm not saying never have these foods. I'm saying timing matters enormously. Want coffee? Have morning or early afternoon, not dinner. Want wine? Have with weekend lunch when you'll be up right hours afterward, not dinner at 7 when bed's at 10. Want something rich and fatty? Make it earlier meal or smaller portion. Key is being strategic rather than complete deprivation, because complete deprivation isn't sustainable and unnecessary. Understanding proper timing. Share this video with one person over 60 needing this information. Parent, grandparent, friend, neighbor dealing with reflux or digestive issues, not understanding why. Send the link, tell them to watch. That action could change their health trajectory. Takes 10 seconds. The sixth habit is going to bed with distended, bloated, overly full stomach from overeating, eating too quickly without proper chewing, drinking too much liquid with meals, consuming gas-producing foods, or any combination. When you exceed stomach capacity or approach it, internal pressure increases. Think stomach as balloon, partially filled means relaxed walls, room to expand, low pressure. Stretch to capacity means high pressure pushing all directions, including upward against lower esophageal sphincter. For already weak sphincter, increased pressure often overcomes resistance. Acid escapes upward. In older adults, this compounds by gastric accommodation changes, your stomach's ability relaxing and expanding to comfortably hold food. As we age, this decreases. Same food volume comfortable at 30 might cause significant distension discomfort at 70. Your stomach doesn't stretch as easily. Large meal exceeds comfortable capacity, more easily creating mechanical pressure promoting reflux. Eating quickly worsens this because you swallow air with food. Air takes stomach space. You don't chew thoroughly, meaning larger particles taking longer breaking down. Food sits longer, prolonged distension. Large liquid amounts with meals, especially carbonated, adds volume without nutrition. Carbonation adds gas needing somewhere to go. Lying down with stomach full of food, liquid gas creates pressure cooker. Something gives, and what gives is lower esophageal sphincter. Gas-producing foods worsen this. Beans, lentils, broccoli, cabbage, onions contain sugars and fibers fermented by colon bacteria producing gas. Eating large, serving at dinner, then lying down means you're bloated, gassy, uncomfortable, all increasing intra-abdominal pressure. Some have undiagnosed lactose intolerance or food intolerances causing bloating and gas, never connecting to nighttime symptoms. What I tell patients: eat smaller dinner portions. Evening meal should be smallest, not largest. Eat slowly, put fork down between bites, chew each bite thoroughly 20 to 30 times until almost liquid. Aids digestion, prevents excess air swallowing. Don't drink large liquid amounts with meal. Sip water as needed. Avoid chugging beverages. Save hydration for between meals. Avoid carbonated evening drinks entirely. If having gas-causing foods, have earlier when you'll be upright and active, helping gas move through. Pay attention to stomach feel before bed. If uncomfortably full, don't lie down yet. Stay upright. Take gentle walk. Give stomach time starting to empty before reclining. George, 69, construction manager from Arizona, convinced he had serious stomach disease, feeling terrible every night. Bloating, pressure, breathing difficulty, waking with acid reflux multiple times. Full workup, endoscopy, imaging, everything structurally normal. I asked typical dinner description. Usually 7:30, big portions because hungry after long day, soda with dinner sometimes 2, eating quickly because tired wanting to relax, then couch by 8 TV and bed by 9. I explained he was doing almost everything wrong digestively. We made changes, smaller portions, no evening carbonation, eating slowly, staying upright until 10:30. 2 weeks symptoms 70% better, 1 month essentially gone. No medication, no procedure. Just behavioral changes, understanding how his system actually works. Now, warning signs: these habits may have caused damage requiring immediate medical evaluation. Persistent heartburn occurring more than twice weekly for over 2 weeks. Heartburn waking you regularly at night. Heartburn not responding to over-the-counter antacids or returning quickly after medication wears off. Difficulty swallowing, dysphagia, especially feeling food sticking in chest or needing large liquid amounts washing food down. This can indicate stricture, esophageal narrowing from scar tissue or mass, or severe inflammation. Any swallowing difficulty needs endoscopy evaluation. Unexplained weight loss without trying, without diet or activity changes, always red flag. Could indicate swallowing difficulty making you avoid food. Could indicate malignancy. Could indicate severe inflammation affecting appetite. Needs investigation. Chronic cough, especially worse at night or first thing morning, not responding to typical treatments, dry and persistent, can signal acid reaching airways. Hoarseness or voice changes lasting over 2 weeks can indicate acid reaching larynx, causing vocal cord inflammation. Chronic throat clearing, feeling lump in throat, these are laryngopharyngeal reflux symptoms. Chest pain, even if convinced it's reflux, even if feels like burning, needs evaluation because heart disease can mimic reflux and you cannot afford guessing. Chest pain, especially if severe, radiating to arm or jaw, associated with shortness of breath or sweating, call 911 immediately. Don't wait. Don't assume it's heartburn. Nausea without obvious cause, especially if persistent. Vomiting, especially if seeing any blood, or if vomit looks like coffee grounds indicating bleeding, this is emergency. Call 911. Before you close this video, I need 4 things from you. These 4 actions take less than 60 seconds, but could literally save someone's life. First, hit like button so algorithm shows this to more people needing information. Second, subscribe if you haven't. I post evidence-based digestive health content weekly. You want to make sure you don't miss. Third, share this video with someone over 60 needing to hear it. Parent, grandparent, friend, someone in community dealing with reflux or digestive issues. Send link, tell them watch. Fourth, comment below. Tell me which of these 6 habits you're committing to change first. And if you want, tell me what state or country you're watching from. I love seeing how far information reaches. Public commitment increases follow-through, and I read every comment. Thank you for watching to the end. Fact you're still here tells me you're serious about your health or someone else's health, and that matters. Please take this information and use it. Make changes. Get evaluated if needed. Don't ignore symptoms. Don't assume what you experience is just normal aging. Much attributed to aging is actually accumulated habits that can be changed. You have more control over digestive health than you think. Use it. I'll see you next video.